My name is Roberto Lezzi. I'm an interventional radiologist and I work in Fondazione Policlinico Universitario Agostino Gemelli, IRCS, Rome, Italy. And I'm mainly involved in the treatments of oncological patients, and I work in one of the biggest European private hospital based on oncology, and it is one of the main hospital for patients with the liver tumors as well as for gastrointestinal tumors or gynecological malignancies. And it is more than 10 years that I usually perform ablation, and we usually perform ablation procedure for the treatment of primary as well as secondary hepatic tumors, and also for lesions located in the lung, kidney and bone. Interventional radiology team in our hospital usually perform more than 2,500 treatments each year under fluoroscopy, US and CT guidance. It is well known that the main issue when performing an ablation procedure is to obtain a curative treatment. That means to be able to obtain an adequate necrotic area, not only covering the lesion and the tumor, but also providing a safety margin of at least 5 or 10 millimeter in size to minimize the chance of residual tumor as well as of local recurrence without complications. So it is very important to obtain a safe and an effective procedure. So we need to obtain a consistent and stable delivery of energy to the solid tumor, targeting the tumor precisely in a short amount of time, trying to obtain a controlled and spherical shape of ablation zone. With the attempt to perform a tailored procedure, we usually use radiofrequency or microwave as well as cryoablation, mainly selected based on the target organ to be treated, histology, clinical condition, number, size and location of lesions. And it is mandatory to work in a multidisciplinary approach and to have the possibility to work in a multimodality approach, in which you can discuss every patient with your colleagues, a pathologist, oncologist, radiotherapist, and diagnostic and also interventional radiologists as well, in order to define which is the best treatment for each patient. In the last years, we are performing many ablative treatments for lung and liver as well, using jet tip from RF Medical. Jet tip is an internally cooled and perfused type electrode. A precise amount of physiological saline is perfused during RFA ablation into the tumor through the side hole of the needle electrode to increase conductivity, preventing tissue vaporization and charring. And the controlled rate of saline infusion allows to prevent any rapid increase in impedance, and allowing the generator to deliver more energy and therefore achieve a larger ablation, spherical ablation with better safety margin. Using this approach, we were able to obtain good results in terms of safety and in terms of efficacy for the liver and also for the lung lesions. We use jet tip for the treatment of primary and secondary hepatic tumors till 3.5 centimeter in size to obtain a large spherical necrotic area of about 4.2–4.5 centimeter to provide adequate safety margin in about 10 minutes using a low profile needle with a low complication rate with an excellent safety profile. Advantages of using this device can be highlighted in the treatment also of lung lesions, in which the perfusion allows to overcome limitation in RFA ablation in this particular organ, characterized by an higher impedance that reduces the energy deposition, causing a lower temperature increase and potentially an increase in treatment failure rates. Also, in this particular type of lesion, we are usually able to obtain excellent and controlled results, as also we published in the last article on the European Review, in which we discuss the possibility to obtain excellent results in lesion up to 4 centimeters in size without significant complication rates. By using a multi-probe protocol or combining thermoablation and chemoembolization, you are able to treat a larger lesion than 3 centimeters in size, both primary or secondary hepatic tumors. You can treat complex lesion located in high-risk position near the diaphragm or a Gleason capsule, and also treat lesion in high-risk patient with an high risk for bleeding, because you are performing thermoablation and then chemoembolization, in which you can perform embolization, that is the treatment of a potential complication of ablation, that is bleeding. It is a case of a 78 years old man with pancreatic cancer and liver metastasis, refractory to standard chemotherapy. We discussed this case in a multidisciplinary oncological board, and we decided to combine local regional treatment together with systemic option. Interventional oncology is the fourth pillar of oncological treatment, so you can combine local regional treatment with surgery, chemotherapy or radiotherapy, and it is a case of patient who we decided to combine systemic treatment with the local regional treatments. We have two big lesions in the right hepatic lobe, more than 5 centimeters in size, the first one, and 3 centimeters the second one. And then we combined ablation with blunt embolization in order to obtain a larger necrotic area, using two RFA jet tip needle together in order to obtain a good results in a very few minutes. DSA not allowed to recognize the lesion because we are dealing with hypovascular lesion. It is very complex, but we put the needle, the two needles together in order to obtain a good results in the large necrotic area. And after that you can see the check which you have the large devascularization of the liver, and it is completed with blunt embolization in order to obtain great results at the final control. It is a case of a 79 years old patient with ACC. As you can see, in 7-8 segments of 5 centimeters in size. We discussed this patient in our multidisciplinary team, and based on a clinical condition, size, and location of the lesion, we decided for a combined treatment. As you can see, there is the feeding artery here, and there is the big lesion. In this type of lesion, we usually perform a combined treatment, combining together ablation and then chemoembolization.